Dr. Meir Magal joined the Wesleyan faculty in 2002 and has been an active member of the Wesleyan community. He earned his PhD in Human Performance Exercise Physiology, an MS in Exercise Science, and a BS in Exercise Science, all from the University of Southern Mississippi. He's been a member on a number of professional organizations, one of which is the American College of Sports Medicine, ACSM, of which he is very active. He has served as the director for numerous honors projects. The research conducted in many of these honors projects has been presented at conferences, sports, science, and medicine. He recently had chapters accepted for publication in textbooks on exercise science. The chapter topics focus on the benefits and risks associated with physical activity, and I think that's what we're going to hear about today.
Right.
He's a great colleague to have. Please welcome him.
Thank you. Appreciate it. Thank you. Thank you very much. All right, so what I'm going to talk about today, I'm going to talk about updating the American College of Sports Medicine pre-participation exercise screening guidelines. So generally speaking, every 4 years, the American College of Sports Medicine is publishing the guidelines for exercise testing and prescription. And this guideline has everything and anything related to exercise prescription, screening, how to deal with different disease conditions in respect to exercise. So very, very important guidelines textbook in our area. If you are working with the trainer, if you had the opportunity to work with the trainer, and the trainer tells you that you need to exercise for 20 minutes at a certain intensity and do this and that, that's where it's coming from. So these are the guidelines. A lot of other organizations use the same guidelines. I had the privilege to be asked and accepted, now it's over, to be an associate editor on the 2017 guidelines, which is the book on the right. During my talk, I'm going to talk about current guidelines because the current guidelines will carry until June 1st. And after June 1st, it will turn into the new guidelines, the book on the right, the 10th edition. In actuality, a few papers came up, and I'm going to discuss these papers, that part of them are mentioned over here. So we do follow some new guidelines as well. So it's not just the book. There are some publications that I'm going to talk about. So if we look at the current screening, if I want to screen something, and I do, I'll take a step back and I'll mention that. The screening that we're talking about is not associated with congenital diseases. They are dealing with acquired diseases. So we're talking about heart disease that are being acquired throughout life. Lack of activity, bad eating diets, inactivity, and so forth and so on. A lot of times you hear about those young folks that go outside and unfortunately die on the field or on the court. That's a completely different reason. So this is not acquired. This is something they were born with, some kind of a defect. So we're not going to talk about that. We are talking about screening people to be able to exercise and looking at the risk of developing some kind of event during the activity. Okay? So the way that we do it today, so currently, what we have to do is we're looking at CVD risk factors, cardiovascular risk factors, and we're going to talk about these. We're looking at some signs and symptoms such as shortness of breath, chest pain, dizziness, all of them that occur during exercise, and we're looking at non-cardiovascular pulmonary, renal, and metabolic disease. So under these conditions, and I'm going to talk about a certain combination of these, we may say to, and when I say may, when I say we, I'm talking about exercise physiologists. We may say to individuals, you need to stop, you need to go see your physician before you start the exercise, because the risk that something will happen is so high that we would like you to go see a physician before you start your exercise session. All right? So this is where we are today. These are some of the risk factors that we currently have, and the reason we list this risk factor is because each and every one of them is individually related to cardiovascular disease. And some of the risk factors are age, family history, cigarette smoking, sedentary lifestyle, obesity, hypertension, dyslipidemia, which is problem with cholesterol, and prediabetes. So each one of these, if you have them, they have been shown in different research projects to individually be related to heart disease. You have these, any of these, increase the risk of having heart disease in the future. Okay? Now, some of them we can't do anything about. For example, age, can't do anything about that. Health history, we cannot do anything about that. We need to be aware of them so we can do something about it. Sedentary lifestyle, we can do something about that. Obesity, we can do something about that. Hypertension, definitely do something about that. Dyslipidemia, the same thing. And prediabetes, the same thing. So some of them we have control over, some of them we do not have control over. So what we do, after we do that analysis, we're looking at risk factors, we're looking at signs and symptoms, and we're looking at known diseases. And then we classify our participant or client into one of three risk levels: low risk, moderate risk, or high risk. Now you can see that the one on the far left, low risk, these individuals are asymptomatic, which means they have no symptoms when they exercise, no shortness of breath or chest pain or anything like that, and they have less than 2 risk factors. The one in the middle, moderate risk, asymptomatic, more than 2 risk factors. So again, no symptoms, but if you have 2 or more. And then high risk are those people that have known diseases, symptomatic, and so forth. So out of that, we can draw one of 3 different conclusions. And they usually associate with, do they need to go see a doctor before they exercise, yes or no? When they see a doctor, do they need to go through an exercise test, yes or no? And then lastly, does a medical doctor need to be present if we do an exercise test? And you'll see that for the people on the left side of the screen, if you're at low risk, all the answers are no. And it's divided over there to moderate exercise, vigorous exercise, just talking about the intensity of the exercise. Okay? So if you're at low risk, you're good. There is no problem at all. You can go and exercise. You can go and do whatever you want to do without seeing a physician. If you're at moderate risk, that's a problem. Because if you want to get involved with vigorous exercise, right in the middle of the screen where it says medical exam, if you want to get involved with vigorous exercise, you need to go and see a physician ahead of time. And that's a problem. And I'll explain why it's a problem in just a second. All right, so we mentioned that individuals with moderate risk or high risk need to go see a physician. This is the problem that we are having. Risk factors, as I listed before, if you don't know them based on ACSM guidelines, it's a yes. So if I have a student coming to me and say, I would like to exercise, and I say, great, let's screen you and then you'll be able to exercise. Or where it happens often over here, we have staff and faculty members that participate in our program and they come to us and they say, I would like to exercise. I say, great, let's do the screening, you'll be good to go. So if either a student, faculty, or staff come to us and say, I would like to exercise, and then I ask questions like age. Everybody should know their age. So that's okay. We can mark it off or not mark it. That's okay. Family history, most people know their family history. And family history is usually, if we go back, and I didn't want to get too much into that. Family history has to do with if you have a family member, first degree relative who died early due to heart disease or anything like that. Most people know that. You should know if you're smoking or not. Some people don't know what their blood pressure is. I can measure blood pressure, so we should be okay with that. Some people don't know the cholesterol level, and that's a problem. Some people don't know their glucose level, and that's a problem. So theoretically, you may have 2 risk factors, but because we don't know them, we have to mark them off. Or I'll send you to your doctor, make an appointment, and we'll figure out what it is. So one of 2 things happen. A lot of people come back and say, I just saw my doctor like a month ago. I don't want to go and pay money. You know what? I'll exercise by myself. And I said, that's fine. That's your choice. That's number 1. Or number 2, some people just say, I don't want to exercise at all. It's too much work for me. I don't want to do it. All right? So what happened is, in reality, we are pushing a lot of people away. Okay? We're pushing a lot of people away, and that's a problem because we're trying to promote exercise, not push people away from exercise. As part of being an editor of the guidelines, we are responsible to set the new guidelines up, okay? The previous guideline came in 2013. The new one was published about 2 weeks ago, 2017. The editorial group start working on that new guidelines in January 2014, which means the next guidelines are going to come up in 2021. It's every 4 years. Those folks that are going to be the editors on that one going to start working on it January of 2018. That's when you start working on it, 3 years ahead of time. And the reason is, it takes us about 2 years from the minute we start to the minute we finish, which means the book was done early last year, but then there are other textbooks that carry that information, okay? ACSM textbooks. So we have to publish that book relatively early. So as we reviewed the information, we came across this article. And this article came early in 2014. Information from the National Health and Nutrition Examination data, 2001, 2004. It's a large database that you can look into. It's public information, and you can dig stuff out. People voluntarily give their information, age, height, weight, so forth and so on. So Whitfield et al. Look at about 7,000 adults, and this is what they found. They found that when they apply the screening procedures that we have at this time, that I described to you, roughly 90% of US adults age 40 and above will have to go see a physician in order to get clearance. Every time you have such a large percentage of participants that are flagged, something is broken with your tool. We have an issue. So a tool should not scrutinize 90% of the individuals. We have a problem. Something does not add up. And I gave you an example of a student or a faculty or staff member. So the issue that we need to consider, do we really want to block young individuals, 21, 22, 23, think about our students, from exercising just because they don't know their blood glucose and cholesterol? And younger individuals are less likely to go see a physician than a bit older individuals that have yearly physicals and so forth and so on. So we start thinking, we need to do something about it. So what ACSM did, it convened a meeting, a roundtable discussion in June 2014 to review all the literature and try to think about how we can make this process a bit better. How can we do that? And over the years, with the guidelines, we moved from so-called expert opinion to evidence-based studies. The first guidelines was published about the middle of the 70s. At that point, there was not a lot of scientific data that concerned with the safety of exercise. So what we did, we went to all those experts, so-called experts, cardiologists, exercise physiologists, and we asked them, what do you think? Should we tell people to go see a physician before you start exercising? Or someone start exercising? They say, sure, it's a great idea, let's do that. But today we have evidence. We have studies to demonstrate what direction we should have. And this is 45 years later, so that's okay. So ACSM gather expert in risk assessment, preventive cardiology, public health, exercise physiology, practitioners from the field of medicine, clinical exercise physiology. We gathered a large group of individuals, all of them are listed over here, and we tried to think about what things can we change in order to make this process better, in order to make this process a bit more efficient, in order to make sure that more individuals are exercising and not less. Okay, we would like to reduce barriers. The next few slides, I'm going to show you studies that look at meta-analysis, longitudinal studies that were done over a long period of time. So we followed the same individuals over 10, 20, 30 years time period. Okay? And it's not just one study, it's many studies. For example, this graph is coming from a study that looked at 1.3 million hours of training of individuals. Okay, so that's a lot of data we have over here. All right, so what are we looking at? We are looking at benefits of physical activity and something we call a dose response. Dose response is very similar to what you do when you take a medication. The greater the dose, the more response you're going to have. If you take 1 Advil, your pain may go away. If you take 2, I don't know if you're supposed to or not, but you're going to feel less pain than what you take 1 Advil. But that's the relationship, dose response. So this study showed us that the more we do, the better physical shape we are, the lower the relative risk is to have some kind of cardiovascular disease. We usually talk about myocardial infarction, which is a heart attack, or sudden cardiac death, okay? And it's pretty obvious, okay? Any question about this? Yes, sir?
What's the percentage?
That's the number of days or sessions that you are active, volume. How much exercise do you do? 0 is doing nothing, 100% is the most that you can do without having the risk outweigh the benefits. Okay? So this is one study. We have another study that looked at dose response. Very, very similar type of study against big data. And what we see over here, we see a relationship between relative risk of myocardial infarction and relative risk of sudden cardiac death in respect to the number of days one may exercise per week. And we see that for each additional day that one is exercising, he or she reduced the risk of myocardial infarction by about 47%. And they also reduced the risk of sudden cardiac death by about 30% for each additional day per week. Which means the more you do, the better off you are. Now, I want to say, before you go out there and run 5 marathons in like a month, don't go crazy, okay? There is a limit. You get to a certain point where the risk of musculoskeletal injuries, orthopedic injuries, outweigh that. All right, so there is a point. We'll talk about it just a little bit. All right? Yes?
What about the sudden cardiac death? Is there any explanation for why that one is less linear and you have some that seems like kind of skewed from where you'd expect them to be?
No, not that I've seen. The rates in the population of myocardial infarction and sudden cardiac death are completely different. So these are mortalities. These are morbidities. Right. So you will see a difference. And I'm not sure how it comes into play. I assume that the analysis was somewhat different. That's the best of my knowledge, the best extent of my knowledge.
Let me throw in, that's actually normal physiological data. You draw the trend line through all of it.
Right.
It's like the points are kind of all over the place, but you can see the trend pretty clearly.
Right. I agree. Any other question? All right.
What is the term myocardial
Infarction.
what does that mean?
It's heart attack. So infarction of myocardial is the heart muscle. It's an infarction of the heart muscle. All right, so moving from looking at dose response to some risks that are associated with exercise, but some good things as well. All right, so when we look at this graph, and I'm going to shift over here, I want you to concentrate at 3 different points on the graph. So this is the first point, right over here. So we have active subjects and sedentary subjects. For the discussion that we're having today, I want you to think about someone who does not exercise and someone, that person, adopted exercise, and we're looking at the same person 6 months later. Okay? The same person before he or she started exercise and after they started exercise. Okay? So if we're looking at the same person before they started exercise, the relative risk of AMI is acute myocardial infarction. The risk was 1. If they exercise on a regular basis, the risk is half of that. That's at rest, which means if I'm not training at all, I'm doing nothing, my risk today is double than what it would be in 6 months if I'm starting to exercise on a regular basis. Okay? If we take this sedentary individual, and that sedentary individual go and exercise outside, that's something he's not used to, vigorous intensity, his or her risk goes up 100 times. So during the activity, the risk is 100 times higher than what it is at rest. Now, some of you may say, oh, that's great. So what do you do with training? So this is what happened with training. The more training that we do per week, the lower the risk during exercise. So if you exercise 5 times a week and you do unaccustomed vigorous intensity exercise, your risk over here is only 4 times what it is at rest. So exercise does come with a risk. But I think it's very clear what's the difference between being active and being sedentary. Now, what we're trying to do with screening is minimize that. I want to lower that risk as much as I can. So I would like to screen individuals. That's why we're screening individuals, because we would like to lower that risk. Yes. Yeah.
So if you're in the 5+ a week version,
Right.
your risk is half of what it would be if you never worked out?
No. At rest.
At rest, I mean.
At rest, yes.
Right. But when you work out, it's twice the risk.
Right. Exactly. So theoretically, this line, theoretically, this person will come up to this line if he or she are exercising on a regular basis.
But if they use vigorous exercise, their risk is twice what it would be if they weren't exercising at all.
Right. So sitting down, without doubt, you have less risk of having a heart attack. No doubt about it. But inactivity is directly related to heart disease. So there is a chance you're going to develop heart disease sometime in the future. And what we're trying to do by screening is reducing this almost to nothing. And I'll show some data about this. Yes, Evan.
What did they base the vigorous exercise on?
It's vigorous. It's a term we use in exercise physiology, and I'll try to do my best to explain it. It requires some math skills. So generally speaking, Generally speaking, we have something that is called VO2 max, which is the highest intensity capacity-wise you can do. So if you go and you run a sprint, and you're working yourself to maximum capacity, that's going to be VO2 max. The difference between vigorous and moderate is up to 60% of that capacity, and vigorous is anything above that capacity. And there are different activities that can be defined by their intensity. So for example, playing a single match in tennis, that's vigorous intensity. Playing doubles is moderate intensity. So we have some tables that I did not bring with me, so you can classify different activities. And if you work with the trainer over here, and I'm not promoting that, although I am, your trainer will be able to tell you what is vigorous and what is moderate and what is vigorous intensity. It's a calculation they can do based on heart rate. Jeff.
Clarify.
Again?
What I'm thinking of is sometimes you see studies that say you take this medication and it lowers your heart attack risk by 50%. May not mean all that much if it's based on a study with 1,000 people and only 2 of them had heart attacks.
Right.
Without the medication, and one has it.
Right, so there are different sides to it. So all the studies that we're talking about over here, this is medication free. So this has nothing to do with medication, which means this individual that is not exercising and his risk is double, may have high blood pressure, may have high cholesterol.
I recall hearing click and clack when you're talking about exercise, and one of them suggested that, well, they may die a little early, but they won't spend all that miserable time on a treadmill. And in the long run, the differences between
that's
and one.
Yeah, that's a good question. I'm not sure, but it's very similar to say, I can go and eat fattening food now because I take a cholesterol medication. It's the same thing. I mean, your cholesterol is going to be low regardless. And I had some patients in cardiac rehab when I worked a few years ago. Hey, I can eat whatever I want to eat because I'm having this medication and it's magic. I ate so much food yesterday and my cholesterol is like. Yeah, eventually you're going to get a heart attack, even with the low cholesterol, because you're eating so unhealthy and you're not exercising enough. That's a good question. As far as I know, a lot of this data is medication-free. So I don't know where the line, I assume the line will move a bit up, meaning the risk will be lower with medication, but we're not promoting medications. I mean, our motto, and you can ask my student, exercise is medicine. That's what we're trying to achieve. It's very similar. I have some friends that I play tennis with, and they take like 5 Advils before they get on the tennis court because there is so much pain before they start. I'm like, 20 years down the road when you're going to have liver cirrhosis, that's not going to be fun. So, yeah, it's give and take, I guess. All right, so this is a slide that looks at the absolute risk. So different studies look at what are the chances or what are the rates of people having sudden cardiac death and heart attack during exercise. And as you can see, it's minimal. It's close to nothing. Now the problem is it's close to nothing and it's all great as long as it's not you or your family member. So what we're trying to do is, again, minimize that risk. Okay? If you can minimize the risk, the chance that something will happen is lower. That's why we do screening. Okay? And there are different studies over here that show that, and you can see it's really close to nothing. Other things that we found out. So we talked a little bit about risk factors. We talked a little bit about exercise, the importance of exercise. But we found out that signs and symptoms are extremely, extremely important. This study looked at prodromal symptoms, so symptoms that occur prior to, reported by 45 subjects within 1 week of their sudden cardiac death. So these individuals passed away. And this is what they reported a week before. We have chest pain and angina, which is chest pain, increasing fatigue, indigestion, excessive breathlessness, shortness of breath, ear or neck pain, upper respiratory tract infection, some things that may be associated with heart-related disease, not infection, but heart-related disease. So maybe we need to look very closely at signs and symptoms. And we did over the past. I mean, the current guidelines, we still look at signs and symptoms. So obviously, this is a very strong data that we need to look at. All right, so what do we know? So reviewing the literature, we know that the relative risk of cardiovascular event transiently increased during vigorous intensity exercise, so we need to be careful with that. Exercise-related acute cardiac event is low in healthy and asymptomatic individuals. So as long as you're asymptomatic and disease-free, you may be okay. And the chance of sudden cardiac death and acute myocardial infarction is the highest among those with underlying cardiovascular disease. Now, the fact that you exercise and you do not have chest pain or shortness of breath does not mean that you do not have cardiovascular disease. It does not mean that we, each one of us over here in the room, have a buildup of plaque within our arteries. It just didn't get to that point that is significant enough to cause issues. And also those that participate in unaccustomed, vigorous physical activity. So the big picture, what we're trying to identify is individuals who may be at risk for serious acute exercise-related cardiovascular event, including sudden cardiac death and acute myocardial infarction. So when we are screening individuals and someone comes to us with 5 risk factors, does that mean that there is a chance that they're going to die on the treadmill or the bike? That's what we're trying to assess. Now, we looked at different data, and we found that the answer is no. And I'll show you that in just a second. So the changes that we need to make, and you saw this slide before. It was like the 3rd slide, I think. The changes that we need to make is we need to remove pulmonary disease from the list of diseases. We thought that if someone has a pulmonary disease, that means that he or she has an increased risk of cardiovascular disease. That's not the case. The case or reality is a lot of people that smoke have both heart disease and lung disease. That's the only relationship. So having a pulmonary disease does not, by itself, increase the risk of cardiovascular disease. We're going to do away with low, moderate, and high risk base CVD risk factors. We're going to remove pulmonary and pulmonary, and we're going to concentrate at other things that we discuss. In regard to risk factor, I just want to point out the following. Risk factors do not play an important role in the decision, screening-wise, that someone may have an event when they exercise. Now, I want to be very clear on that. Having a risk factor is not good for you. Increase the risk of having cardiovascular disease. But it does not mean that if you have high blood pressure and high cholesterol, as soon as you step on the treadmill, you're going to get a heart attack. That's not the case. The case is increasing the risk for those diseases. So, for example, if we look across the United States, roughly 65 million Americans have high blood pressure and high cholesterol. Okay? That's roughly 20% of the population. Yet, and I heard someone talking, they say only 600,000 people die every year from heart disease. So the relationship is just not there. There's many people with risk factors, but not that many people die from this disease, especially during exercise. Especially during exercise. And I show you that the rates are very, very low. All right, so what's new? How are we going to change it? So this is what we're going to do next. We're going to look at, and I'm talking about the screening procedure, we're going to look at the individual's current level of physical activity. That's obviously important. I showed that in the graphs. We're going to look at the presence of signs and symptoms or known cardiovascular, metabolic, or renal disease. We remove pulmonary from that list. And lastly, desired exercise intensity. Because if one would like to exercise at vigorous intensity, that increased the risk greatly. And I show you in that graph that everybody has question about. Okay? What we're trying to do, the bottom line, eliminate potential barrier because we would like more and more people to exercise. And number two, reduce the financial burden that is placed on individuals and the healthcare system. We do not want to send more and more people to see their physicians. It costs money to the individuals. I'm sure that each and every one of you had the opportunity to go see your physician at some point. It costs money. Okay? It costs the school money. So removing that burden is important. And the most important thing, we would like people to exercise. That's really, really important. Out of this roundtable discussion meeting, we had two papers that came out. This is one of them. This one was published in late 2015, around November, where we discussed the different risk factors, we discussed the different signs and symptoms, we talked about the changes that we're going to make to this whole process, and I'm going to show you that in just a second. Another paper came out last April, and this paper actually was geared toward professionals in the field. So we took the paper with a lot of scientific data and we kind of transform it to what do the exercise physiology, exercise professional in the field, what do they need to know? What do they need to do? And this is the big new figure we put together. And you'll see on top, I think it's a bit overwhelming. There's a lot of information. So I'm going to take one side at a time in just a second. But what we did, and this is the new logic figure we're looking at when we're screening individuals. What we did is, the first question we asked, do you participate in regular exercise? Because participating in exercise is extremely important. If you answer yes, you move to one side of this figure. If you answer no, you move to another side of the figure, screening-wise. All right, so if you answer no, you do not exercise on a regular basis, there are other questions to be asked. If you do not exercise on a regular basis, do you have known diseases? Do you have signs and symptoms? This is the next set of questions, and it's listed over here. So if you do not have known diseases nor signs and symptoms, you don't need to get medical clearance. You're good to start exercise. Start exercise intensity at light, and then move to as much as high or vigorous intensity. If you have known disease, if you have a heart disease, but you're asymptomatic, you have no signs and symptoms, medical clearance is recommended. But in the meantime, you can start exercising because we know that exercise has many benefits to it. The sooner you start, the sooner you're going to start that benefit. You're going to get something back. And again, you need to start at moderate intensity or no more than moderate intensity. Yes?
How are they finding the people who are, what are they using for asymptomatic, but they have known heart disease? Because if they're asymptomatic, maybe they didn't know to get checked to know they had.
Right. So these are individuals, not just students, faculty and staff, whoever. You went to the doctor at one point and they find out that in the past you had some kind of, you went to the doctor and you had a heart attack. So obviously that was associated with chest pain, but now it's resolved, which means you're taking medication for it, you're feeling fine, you do not feel any shortness of breath or chest pain while you're exercising, so you're going to fall into that category.
So there's something documented in there.
Oh, yeah. Yeah, so it's not like, I want to clarify, it's not like you wake up in the morning and say, I think I have a heart disease. Okay, I'll mark it as yes. This is something that needs to be diagnosed by a physician. I mean, something that you have history with. So those individuals are usually those individuals that have a heart attack or anything related to that. Thank you. Good question. All right. So if you have signs and symptoms, you cannot exercise. You need to go see your physician. And like I tell my students, if you train someone over here and they raise their hand and say, I don't feel well, I feel chest pain, you call 911. You don't take them to the hospital. You get the ambulance to take them to the hospital. If you have someone that tells you, well, I have chest pain, I'm not sure if it's indigestion, or go to the hospital. Better be safe than sorry. Okay? All right. So now we're looking at the yes side. So exercising regularly. And we have different definitions for these that I left out. So exercising regularly. If you exercise regularly, you don't have any disease, no cardiovascular, metabolic, renal disease, you're asymptomatic, no signs and symptoms, you're good to go. You can continue and exercise. If you have known cardiovascular disease, so you had a heart attack in the past, the example that I gave Meir, you had a heart attack in the past, but you're asymptomatic. So at this point, you're taking medication, your disease condition is controlled, okay? You're exercising, make sure you get clearance every 12 months, you're good to go. You can continue and exercise. If you're currently exercising and you have signs and symptoms, chest pain, stop the exercise, go see your physician. Chest pain or any signs and symptoms, meaning that there is an active disease in your body, cardiovascular disease, that is going untreated. That's what it means. So you need to resolve that issue. Okay? Any question about these two? So this is the new guidelines. Now what I did with a colleague from University of Rhode Island, and that's the second publication, we put together a document for exercise professionals that it's going to be easy for them to follow. And I can attach that to an email if you want me to. I can send it. If you wouldn't like to see it, I'll send it out. But basically, this is a form for the exercise physiologist or the exercise professional to fill out. So my students, in reality, when they meet with their participant, they sit down, they take out this form, and they ask them question by question. They need to mark it. Do you have any symptoms? And then tells you if you don't have any symptoms, or if you do, move to stage 2. Do you currently exercise? Mark yes or no, and then you move to medical condition. Do you have any disease condition? And based on that, you have some guidelines at the bottom of the document that tells you this is what you need to do, based on the slide before that I showed you, the 2 last slides. Okay? So these are some of the publications that I mentioned earlier today. This is the one initially that came from the roundtable. This is the one that was published last April. And the guidelines book came out the beginning of February. It's out there. And last slide, I just want to take the opportunity and thank some other people that are not related to Wesleyan and have not been part of the process, but they really help with putting everything together in respect to the new exercise guidelines, screening guidelines and everything. That's it. Any questions? Yes?
So the word vigorous seemed like a key word.
Yes.
In that even if you exercise on a regular basis, vigorous exercise can increase your chances for those 2 issues. Aside from athletes, why would your average Joe do that then? If they can get by with low to moderate exercise to achieve the healthy benefits from that, does vigorous exercise provide any additional or health benefits that supersede what you can get?
Generally speaking, yes. So the more you do, the more you get out of it, dose response. If you look at what's going on in respect to the world of exercise, there are different fads out there. The one that we have now, and I cannot mention the name of that because of different lawsuits, high intensity interval training. So there are different gyms where people go crazy, go inside for an hour, they almost kill themselves without mentioning names. And the reason is there's a lot of lawsuits out there by specific brands. So I'm going to stick to that. But there are people out there that go into some of these gyms, never exercised before, never do any screening whatsoever, and just do vigorous exercise. You have all those CDs or DVDs out there, P90X, T25. A lot of people are watching The Biggest Loser. I don't know how many of you realize, how many of you watch The Biggest Loser at least once in your life? Do you realize that these individuals are working 7 to 8 hours a day? They're eating about 1,200 calories. Of course they're going to lose 10 pounds. And many of what they lose, a lot of it is just water. Do you know that they do not drink anything on the way of the weigh-in? Now, if I was the producer of the program, I will not tell you that because that's a good TV. But this is reality. This is reality. It's a TV show. Okay? But people see it and say, oh, that's great. You know, I'm going to go and push this tire across the parking lot. I'm going to lose so many pounds. Or it doesn't work that way. You want to lose weight? You need to eat better. You need to exercise. But there is a limit for everything. How much you eat, there is a limit on the low end. How much you exercise, there is a limit on the high end. You need to think about that. Nothing comes for free. There is risk for everything you do, including exercise. Yes?
But where would a person fall, say, who had been to the doctor 18 months before, was cleared, but now they're 52 and their dad died, so they have a parent or a direct family member who died early, and maybe they're a little heavy. So they sort of have, so they're asymptomatic and they have no known condition, but at the same time they have some family history things
Right.
to make it a little more.
So I would say in the screening process, so in the real world, individuals needs to go and get screened by their physician once every 12 months. Once a year you need to go and be screened by your physician. Your physician need to be aware of your family history, need to be aware of your body mass index, and do all those calculations before I do them as an exercise physiologist. In my book, if you tell me I went to my physician, there is my clearance, you're clear to exercise. So I do not supersede, I cannot supersede whatever the physicians say. Now, within the last 12 months, if you saw changes in your health, if suddenly you get short of breath when you walk out where usually you do not, if anything changes, go back to your physician and get rechecked, especially if you have a family history, risk factor. I want to make sure, you guys understand, I'm not saying that we take the risk factors and we throw them away. They're still a very important portion of the health history. The only thing I'm saying is having a high blood pressure and exercise does not necessarily mean you're going to get a heart attack while you're walking on the treadmill. Is it still important? Extremely important. Should you take care of it? Yes. Because it increases the risk of having a heart disease, independently of any other risk factor, by itself. Yes, ma'am?
The peaks, the chart of the
Yeah.
peaks.
You want me to put it back?
Absolutely.
You didn't like the peaks?
So the vertical scale.
The vertical
kind
scale.
of stuff that makes math people nuts, or at least this one.
Right.
Why did they do that?
So these are not absolute number. This is
Do
arbitrary.
you know what I'm saying? I'm saying that I'm bothered that the distance from a half to one, and then from 50 to 100 is about the same as 100 to 200.
Yeah, I should have said it's not up to scale. Yeah.
I know, but it's very, it's visually deceptive.
I think that people,
I understand that. You wouldn't
Yeah.
be able to see the difference in a half to one.
Right.
I get all that.
I think that people in exercise physiology, and maybe even in biology, chemistry, I don't know, we look differently at graphs that maybe some mathematician look at, which everything is up to scale. That's the best answer I can give you.
You understand why?
Yeah, I do.
Yeah.
I do, because it's not one-to-one. I know.
Okay.
I understand. Yes, sir.
The first flow chart you gave us with the less than 2 and then the greater than equal to.
Okay.
Is that the one that you said they came up with earlier without having data, more like an analytical model? Is that the one you said they came up with that they were using based on?
This one is currently, yeah, so this is not necessarily no scientific data, but over time, we increase our knowledge, scientific knowledge, and things change over time. So this is the latest one we have, and this is based on a scientific data. This is based on scientific data. But I think that over time, maybe some researchers were not ready yet to give away risk factors. They were looking for more data. And more data came through, and they say, okay, you know what, the risk factors are not important for screening. It is important for health history, so maybe we can do away with them when we screen.
So this one, is this the one that the article was saying was catching over 90% of people
Right.
4 year older?
Right.
So it was
Correct.
meaning they had to go to the doctor first before they would.
Right. Exactly. Yes. Go ahead.
So in coming up with a new model, you know, a lot of times when you see data that's catching too much stuff, instead of fixing the problem, they just change the model so it doesn't look like it's catching as much stuff.
Right.
Is there that kind of balance going on between, we don't want to send too many people to the doctor, but we also want to make sure we don't leave out people who are at risk?
No, I mean, first and foremost, we deal with people's lives. So,
Right.
you know, you don't change it just because it's going to look better and bring
Yeah.
more people to exercise. I know that all the changes that we made based on scientific data. So that's what the data showed us, and that's what we presented. That's why it was changed. Yes, sir.
You mentioned that you showed us the little form that you give the students for screening
Right.
compliance and all that kind of stuff. How effective would you say the overall screening process is here? Yeah, it says adequate screening.
Well, I got the provost over here, so I will tell the truth. So I think that there is an issue over here that I did mention actually to Dean Naylor at some point. So we have people that come, how many of you exercise over here at the center? They're not part of my program. Excellent, good job. So if you exercise and you're not part of you exercised before is not part of the program over here in the weight room? What type of documentation you had to fill out?
Nothing, I signed my name on the sheet at the desk.
Okay. So we do not do any screening over here. And I talk to different people. I mentioned Dean Naylor because I talked to him about it before. As far as I know, currently they have some kind of a disclaimer. So we do not assume responsibility if something happened to you. Now in the legal world, not assuming responsibility does not mean you're not responsible. Which means if I go and exercise over here in the weight room, and I sign, I assume responsibility. What did you do on your end if something happened to me? Okay, court will come over or prosecutor will come over and say, what did you do on your end to reduce the chance that something will happen? I understand that Meir assumed responsibility, but he walked in and he got a heart attack. What did you do on your end? Nothing. That's what we have at this point now at the rec center. So for the most part, individual comes in, and I think part of the program you have to sign some kind of release form. Is that correct? Part of the weight loss program, training program with the staff. There's some release form, but you're not being screened. So assume responsibility. Or for me, if something happened, that's great. We have some people I work with, and they represented both plaintiffs and defended in court in cases that people sued. So individual went and exercised in a facility, got a heart attack and died. The family sued the facility. Now, if I'm an expert witness for the facility, I would look at this book and I say, oh, you know, these are only guidelines. which means implying you don't have to follow them. It's guidelines. You know, I decided not to follow the guidelines. But if I'm representing the plaintiff, I would say this is the norm. I understand it's guidelines, but these are the norms. This is what most facilities do. And I think we should do the same, probably. This is my own opinion. I don't want to get into anything else. Any other questions? Thank you. Appreciate it.